The federal government unveiled today the first phase of the plan to establish national universal pharmacare. Negotiated with the NDP, Bill C-64 proposes coverage for some diabetes medications and contraception. What exactly is covered depends on negotiations with the provinces and territories. On contraception, the government is proposing coverage for oral contraceptives, IUDs, morning after pills, along with other contraception methods. On diabetes, the government is proposing coverage for insulin, metformin, and other medications often used in combination with insulin and metformin to treat patients with type 2 diabetes. The government also announced its intent to establish a fund to support access to diabetes devices and supplies. The full cost of this proposed coverage was not revealed today. The government says the price tag will be determined after negotiations with provincial and territorial counterparts. Mark Holland is the Minister of Health, and he joins us now from the foyer of the House of Commons. Minister Holland, thanks for joining us today.
Thanks for having me.
So we got the legislation finally on pharmacare, but one of the major things missing from today's announcement is a precise budget, a precise cost on this first phase of the program. What is the range? Can you give us a clear estimate?
Well, let me first just say what it is, because I think it's incredibly historic. This is diabetes medication. There's a fund as well for devices and for syringes and strips. And it means that for so many Canadians who were faced with an impossible situation of, do they pay for their food or their diabetes medication and risk terrible outcomes, they're no longer going to be faced with that circumstance. And it means on contraceptives that women are going to have access to universal contraception, really have autonomy over their sexual health and their bodies. In terms of what the cost is, we don't know exactly. I've said about $1.5 billion, but it's not. I got to be very careful about that because just yesterday, Nova Scotia announced action in this space. Today, Alberta said they're going to be doing things. There's already a lot of provincial spend. We have to negotiate with provinces. So really, we'll have a clear idea heading into the 25-26 budget after we finish these negotiations with the provinces to have a precise answer to that question.
Right. No, I appreciate you can't give us absolute precision, but I can't imagine you would have launched a national program without a budget range. So once you negotiate these deals, say with Nova Scotia, say with whoever, does the federal money then displace any existing provincial money, create a savings for the provincial governments? Is that how this will work?
No, in fact, I've had very constructive conversations with all of my provincial and territorial counterparts and made it very clear we're looking to build upon their existing spend. We want to expand impact. So we want to, we're not going to punish leaders here. Like jurisdictions like British Columbia already have universal contraceptives. We don't want to punish them because we're a leader. We want to work with them, and we want to make sure that there's equity in how much spending is happening across the country. But there's an extraordinary impact in sexual health, which is health. And within the space of diabetes to expand impact and to work with provinces on that.
Okay, so the cost shares between the federal government and the provinces and the territories is to be determined. But how do you see this affecting individual Canadians? Let's start with the contraception end. How much do you think this will save the average Canadian woman who qualifies for this benefit now?
Well, it really makes a huge difference because unfortunately there's too many circumstances that I've heard of when talking to health professionals where women were making a choice to either have an inferior or no contraceptive plan as a result of their fiscal circumstance. So that could mean an unwanted pregnancy, that could mean a situation where they wind up with sexually transmitted disease. I mean, there's a number of different circumstances that could occur. And the other thing that I hope this does, beyond the cost savings and making sure that cost isn't a factor for a woman to get the contraception that they need, is also a conversation about sexual health in this country, to say that sexual health is health. We should be as comfortable talking about, an elbow or a hand as a penis and a vagina. And I think with our inability to have those clear and direct conversations, that lack of information is extraordinarily dangerous because what it means is that people can be manipulated. If you think of low fiscal literacy, that means that somebody can be manipulated financially. It's the same thing with sex. We need to have direct conversations. We need to make sure that people have what they need to be safe in their sexual health, and this is a massive step forward for that today.
Okay, but on cost savings there and the diabetes medication, I mean, how much are we talking about here? That a person who's paying out of pocket for their diabetes medicine right now, what do you think broadly, say, the average insulin-using type 1 diabetic could save because of this program?
Well, it depends. For some people that, I was talking to somebody, where just their copay, they would save about $500 a year, and that's somebody who already has coverage. For somebody with no coverage whatsoever, it would be much larger than that. It would really also depend upon the province and what device would be supported, because there's monitors, there's pumps, there's different circumstances. But it is an extremely significant amount of money. And I think one of the things that's really important, I was talking to Sarah at the Ottawa Health Center, at this Ottawa health team today, who was talking about the fact that they're encountering patients who can't afford syringes, so they're reusing them. I mean, just think about that for a second. Talking about patients who can't afford their medication, so they don't take it, so then they wind up having to amputate a limb, or they wind up with cardiovascular disease or a stroke, or it's so terrible. In this country, we have the solutions. 20 years ago, we didn't. Now we do. To let people suffer like that, it's not only an issue of social justice. I mean, it fundamentally also is an issue of cost savings. Like, why do we create circumstances where we allow people to get that sick when we have a solution? So this is a great example where action, I think, is an imperative.
Right. It's not just hundreds, potentially thousands in people's pockets. That they can take their full regimen of medication by making it more affordable. Okay.